Hi, my name is Taylor Clark. I'm going to present my client single case design on which I chose my patient from the Regional Cancer Center in which I work. Client demographics. My patient is 50 years old. She's a female and Caucasian. She is married and has 2 children from a previous marriage. Her mother is still currently living, but please know that she does not have a relationship with her. And her father passed away when she was young, who was not really involved in her life. She is from Kingsport area and still resides here. A little bit about our patient's history. So, when I meet with the patient, we do a quick assessment, an intake assessment. I actually did a psychosocial assessment on her, so I have a little bit of more background and information just because of why she was referred to me. The patient reports some signs of possible depression and anxiety, but she does not have any definitive diagnosis by a professional. She has not seen one yet. She has been referred. Note that. Currently has been referred. Patient hasn't had any psychotherapy or psychiatry care. She's not been hospitalized for a mental status and currently is not on any medication for altered mental status or any mental health diagnosis. She reported that her mother had some substance abuse and altered mental status. She has been hospitalized multiple times for attempted suicide. She does not know what her mother's diagnosis is exactly and or what medications that she's on, and that's primarily because she does not have a relationship with her. The patient prior to this recent diagnosis of lung cancer has excellent health history. So this is a big change for her. I listed current medications that she's on. These are all recent medications. She has had surgery. The time of this psychosocial assessment, these are all recent medications that she was prescribed. She has had surgery on her lung. She had half of her lung removed. So that's where some of these medications are. And she currently, during the study, is starting a chemo regimen. She hasn't reported any weight loss or weight gain, no substance abuse. She did say that she suffered some emotional abuse, primarily because she was the main contact for her mother, who had alcohol abuse and multiple suicide attempts, in which she was her only living relative. So she was the first that any doctors or anything or her mother called when she needed someone. Her father really wasn't involved much in her life, and which, again, I said passed away when she was fairly young. She did say that her grandparents had a big part in raising her. She stated that her grandmother, though, was a mean old Irish woman and that she would do some unreasonable things, but she loved her grandfather, who was a preacher, loved going to church with him. She did not report any sexual abuse or any physical abuse, just emotional abuse from witnessing some of the things that she did as a young child, and as she grew into an adult, having to take care of her mother. Continued. Her current family situation. Note, I've added extra notes in here on the slideshow, and I know this can be a little bit much to read, but I've added these so if you need a little bit more detail, I'm going to touch on things, but if you want to go back and look and read or go back and touch up on things that I'd mentioned maybe you forgot, it will help explain too why I chose the measurement that I did, the tool that I did, and the simplicity of it, because this patient has so much going on. But her family situation currently, she has been remarried to her husband, Jack Doe, which is an A-list name, for about 6 years now. The patient claims to be happy in a relationship, although the negative aspects of her illness has put a strain on them. She states that her husband is her primary support system, which is wonderful. We always recommend a patient having a primary support system. Her husband was laid off to a certain extent before our study. Now he does contracting jobs, so those jobs can end. He gets laid off for a second time in the study. Note that, please. She has a 20-year-old child who's currently in college to pursue a medical career, and she has a 14-year-old and is very active in her karate. She also has recently come out to her mother, and I'm saying this because the patient is having a hard time dealing with this in her study, that she is interested in women. And her mother is adjusting to that and trying to accept that, and she does have a hard time. The patient currently only has her mother that's still living as blood relative and states that they don't have a relationship. Her mother does have a history, again, like I said, of drinking and suicide attempts. Employment. The patient, interesting enough, was a trauma nurse up until recently. We have filed for her FMLA. But later on, and I've gone back and had to add these things to my slide because even though the study stopped, these are situations that have occurred towards the end of the study that weren't documented initially in my psychosocial assessment. But we had FMLA, we filled out FMLA papers and short-term disability benefits, and she was approved, but she will, as time goes on, they let her know that she will be terminated for her position if she can't come back by a certain time period. The patient worked trauma, like I said, for the majority of her career and then switched to working for HMG as a specialty clinic nurse. She has worked in oncology clinics. She currently is still receiving her disability income, or has started receiving her disability income through Lincoln Financial. She attended college and pursued a degree in nursing and received her nursing license in 1991. She claims Christianity as her religion. She made a statement at some point, and it's mentioned here in our next slideshow under problems, that she's mad at God. And, I mentioned also that she had a relationship with her grandfather who had a big part in raising her and who was a preacher. Next, problems. So this is where we're going to get into addressing problems, and this is what is causing, these are things that are causing her stress. Her problems. The patient currently is receiving treatment for lung cancer. Family is in financial distress. She currently is losing her job. Now at the beginning of the study, she was not. We had filed for FMLA and PTO. She had a prior illness. Please note this. I'm sorry. She had a prior illness in which she had to take FMLA days off for. As such, when she had a prior illness, and then she was diagnosed with this. But she had to have tests done. She had to have surgeries done. All kinds of tests that she had to take days off work before her actual diagnosis and treatment started with us. So she had already had FMLA days and PTO days used before she started her treatment with us. So she, yes, is losing her job. And this happens towards the end of our study. And she's stressed out from what I'm calling in this study, and some of the notes that I'll be turning in with this, a snowball effect from her cancer diagnosis. The patient will be losing her insurance also if she does lose her job. The patient states that she is angry at God and questions how things can go from being so good to her current situation. These are things that were mentioned in our psychosocial assessment, and I have gone back and added things in purposely for this assignment that were mentioned at a later date. Quantifying problems and measurement. The name of the measurement is Daily Overall Stress Level Rating Scale. This is an IRS scale that I have personalized for her. The purpose of this is it's personalized based on the needs of the patient. We'll provide a score each day. The patient will provide a score each day for her to rate her stress level. This will in return make it easier for myself to monitor either her progress or her decline in progress of lowering her stress level or managing it. It's a IRS scale, individual rating scale. I chose this because we can personalize it to her. She has multiple problems going on. Like I said, the snowball effect from having cancer can be quite complicated, so we really want to keep it simple for her to use, but something to hold her reliable. Rationale. I used a individual rating scale again, like I said, versus a behavior observation scale because we can personalize it to her. I chose IRS for a number of reasons, although a BOS, a behavior observation scale, would have worked also. And sometimes again, in my critique later on, I'll mention why. I could have used that and would have liked to, maybe if I felt like she wasn't so overwhelmed with having other responsibilities also. One reason I chose the individual scale is it's easier to manage based on the patient situation. It's easier for her to manage with everything that she's got going on, but it still holds her accountable for identifying when she's stressed out, when she needs to take a time out and do something to relieve that stress. Also chose this because behaviors in relation to stress varied so widely, and the stress was primary a cause of the behaviors. So because she was stressed, she would cry or get upset or not want to get up out of bed the next day. It varied. It was so different. There was a different behavior. It wasn't one behavior in reaction to the stress. I chose the goal to be able to manage her stress level. The administration procedure, who, when, and where, she will rate this herself, and she turns it into me weekly when she comes in for chemo. She will complete the rating at the end of the day, so right before bedtime. And this can be done anywhere, so wherever she's at that day. The reliability and validity of this measurement, it'll be completed by the same patient, the same person every single day. It's her own rating of her stress. It'll be completed at the same time of each day, which is right before bed. She'll have supporting notes that she will actually report to me, and I have summarized those in the daily ratings that she has given me on paper. Patient will send me, will give them to me or send them to me by email each day, her ratings, and I will keep track of them. And then at the end of the week, she can bring me her notes, or when she at the time of therapy, which is normally on Fridays. The patient completes an initial distress screening also at the time of chemo education and a 6-month follow-up distress screening. So this screening is required by our cancer center. It's part of our OCM model, and we have to complete a distress and depression screening at the beginning of each new patient's time of chemo education. So right before they're starting their chemo regimen, we do a depression and distress screening, and then 6 months. And this can really validate if we're identifying the right things in our study as well. So at the beginning when I do this, it matches up with her, the things that she's identifying that are stressors, and that she also rates that on a scale each week or for a following week, what she would rate her scale for that week. And we'll also complete this in 6 months. So even when the study is done, if she continues to do this intervention, in 6 months, we'll complete the study again. And if she is continuing the intervention and that technique, or maybe if she's even found something new, we can go back and look at her rating of the 6-month follow-up scale. Continued. Relevant scoring information. So it ranges from a scale to 1 to 5. Each number indicates a certain level of stress. Oncology distress screening at the beginning of treatment with a 6-month follow-up screening, which is what we just discussed. If that is a different screening, that is not the IRS. That screening is required by our Regional Cancer Center for our OCM, which is an oncology management, oncology practice. And we have to have that in order to be an accredited facility, in which is why we do the screenings for each patient. Now, a 3 is moderately stressed. This is something that she can still manage. It's when it hits a 4 or a 5 and she feels like she cannot manage her stress anymore. So we would like to get it a 3 or below. Each day. Case conceptualization. I feel like the patient again is stressed due to her diagnosis of cancer and the contributing factors that are related to her diagnosis as well as outside factors. She feels at times that she cannot control her stress and it gets to a point where she is so overwhelmed it becomes unmanageable. So like I said, the patient has a quote unquote snowball effect. So she has to worry about finances, who's going to get her to her appointments, driving, work, school, family, bills rolling in. It really affects everything. Her emotions, her worry if she's going to be okay. But please note that she does have outside contributing factors. Her daughter comes out and says that she is bisexual. She's 14 years old. Her husband and her are starting to argue a little bit because of her stress. Her son only makes so much money. She's struggling financially to help her son, who she's always helped, and her daughter. Her daughter is very active in karate, and her husband's trying to work, so she's trying to balance those outside factors, but in relation to a lot of it is to her diagnosis that she can't help like she used to. So the evaluation design, it's going to be an A-B design. We're going to keep it simple. Why this design? It's to assess these clients' needs in the baseline phase and to track the progress in the intervention phase. The advantage of it is a more simple design for the patient to understand and track her own progress. Again, she's a very complicated patient. She's got a lot going on. We didn't want to make too complicated. Also, I was time limited. Her regimen will continue regardless if this design does or not, and we were time limited on the design. The disadvantage is we can't retest the intervention to actually prove that the intervention caused the change. The intervention. Patient provided a list of things that she enjoys doing that brings her peace. Her favorite was taking long walks. So we agreed that she would take the long walk once a day. The patient will take one long walk alone a day unless patient feels the need to do it more due to the increase or lack of decrease in stress. It also has been proven in a study that physical exercise does have an impact on psychological functioning and quality of life. And the link below to that study is here, and you can click on that. It takes you directly to the article. This is my scale, my data analysis. So here in the baseline, you see a pretty high level of stress. You see the variability in it, but it bounces. It's not a high variability. It's actually low. It only bounces between a 5 and a 4 here for the first 2 weeks of the baseline phase. When you get to intervention, you can see a slow descending trend that bounces. It starts here at a 5, then it goes to a 4. After that first week of intervention, it drops down. You no longer see any more 5s. Okay, so we drop down to 4s. There is some low variability. It goes between a 4 and a 2. And you notice that we don't ever get below a 2, but we've gotten below that goal mark. So here We've met our goal multiple times, which is to be a 3 or below. It's not stable, but it is low variability, and you can see a descending trend or low a decrease in the level of stress. Now, again, like I said, in a critique of something that I would do different is to do an ABA design to actually retest and see if this intervention was the cause. One weakness of this design is that there are contributing factors that could have naturally lowered her stress, as far as being approved for financial assistance or her husband getting hired again on another job, things like that that have happened that would naturally decrease her stress. Conclusion. So the strengths of this, like I said, it's an AB design, it's consistent, and it's personalized to her. The weakness is the change. I would change to another design probably. If I had more time, I would do an ABA design and see if the intervention was actually the cause of her the decrease in level of stress that she had that you saw in our graph, the noticeably decrease in the level of stress. And it did happen after intervention phase. Now, really, you could argue that it was her actually taking the time to be by herself, do something that she enjoys to take her mind off everything else. Um, she, and that was another weakness, it just, other factors, good things that happened, and we wanted to continue, to happen, could have naturally just decreased her stress as time went on. Good things began to happen for her. The client, like I said earlier, she participated in the design and enjoyed it. She's a past nurse. She loved that I wanted to do this with her, and she agreed to it. She claimed that it actually held her accountable to actually take the time to relax and give her time to herself, to be alone and to reflect. And she said that walking made her feel not only more relaxed, but it also made her healthier. Made her feel healthier in her current situation.